So in this podcast, we take on the subject of female infertility. Now, instead of calling a gynecologist, I decided to talk to one of my colleagues who is a chiropractor in North Carolina. And one of the reasons I chose him is a lot of his videos have been very informative, both for providers in the functional medical world as well as for patients. And a common theme I had seen repeatedly shown in his videos were about how women who struggled to conceive come to see a chiropractor probably for a functional medical approach and actually land up conceiving. And I've seen this in my own practice, but he does a great job with educating people on how to delve into it. And I decided this would be a good time for me to talk to him about his approach. So for those of you struggling with this specific issue of infertility, and you've been through the whole workup by the regular medical system, particularly getting your hormones checked, your spouse has been checked. If you're struggling and feel, hey, I don't have another answer, or if they actually found an antibody, like the antiphospholipid antibody that causes blood clots, therefore you have to be on heparin for the rest of your pregnancy, this is a video for you. Somebody who has to be on a medication to sustain pregnancy, that's an unnatural way of sustaining the pregnancy. I understand it's very important, but how can we actually resolve this autoimmunity? And let me tell you, this is not really very difficult. A lot of our patients come to us for other issues, and as we work on their inflammation or gut health or their stressors, we actually find halfway through the process, they actually get pregnant and they're overjoyed. We're overjoyed because they didn't realize this was one of the reasons the disease process was actually affecting their ability to have a child. So we call it the terrain. Your body needs to be healthy in order for you to have healthy kids as well as a healthy and stress-free pregnancy. There is also one other very good reason as to why you should not stress or force your body to be pregnant is because whatever is causing your initial infertility or the inability to have the baby is what is going to cause your chronic health issues later. It's the same thing, whether it be polycystic ovarian syndrome. People with polycystic ovarian disease eventually do land up having severe depression, hypertension, cardiovascular risk, diabetes, and similarly autoimmune condition. You may have sustained a pregnancy by getting heparin and other medications or a progesterone supplementation, but eventually, once you're done with it, your body has been forced to do something it should not have been forced to do, and all of your health simply goes to hell. So that's why it's very important to address the root cause right from the get-go before you get pregnant. Therefore, one of the things I want you to get out of this podcast is, remember, there is always a solution to a problem, but the most important thing is you got to understand the problem. So without any further delay, here is my discussion with Dr. John Bartemus. So good afternoon, everyone. I know we are at an odd time today instead of our usual 3:30. And I'm here with Dr. John Bartemus, who is from Charlotte, North Carolina. So John, I haven't introduced you formally in any way, shape, or form.
Okay.
But let's start off with, I know you are trained in chiropractic care, right? Chiropractic care. So let me ask you this. Why did you decide to go to chiropractic school? Was there a story behind, or it's just something that you always wanted to do?
No, actually, I never. I guess it's kind of interesting, but I'm biased. I grew up always knowing I was going to be a doctor,
Okay.
but I also grew up with the dream to make the NFL as a football player. And
Mm,
so that paradigm of making the NFL football to me growing up was top. So I wanted to do anything I could naturally to optimize my outcome on the field. So
okay.
I was always into fitness and nutrition as a way to boost performance. Once I went to college, I went in as bio pre-med because I always had this doctor thing in my mind.
Hmm.
But I got to the end of undergrad and said, hey, I don't want to live in a hospital and I don't want to give medications. So what do I do? And I'd never heard the word chiropractor, but my career counselor said, hey, why don't you check out chiropractic? So long story short, I shadowed a guy. He was seeing cancer patients and athletes and doing acupuncture, and people were happy when they came in and happy when they left. So
Mm.
it's like, this looks cool. I'll do this. And the philosophy was in step with my, hey, let's do goal. So it all made sense.
Okay, so basically you wanted to avoid the sick care from the very beginning. It was all about the health and wellness.
Yes. Yep.
Okay. And that's very interesting because everybody who goes to medical school goes in saying, I want to help people who are sick. And I
Yep.
remember growing up in India, Mother Teresa used to do a lot of charity work.
Mm-hmm.
And one of the goals I used to think is when I grow up, I'm going to be a doctor and go and work with her or work with her group. And then came along the boys, right? And then it was like, screw that part.
Yeah.
But then going into medical school, I never knew that there was a wellness aspect because we are raised in a culture, whether it be in India or here, that disease is inevitable.
Mm-hmm.
And the only way to address any disease state is to go to a physician. So having gone to chiropractic school, and I know today we're going to talk about functional medicine,
Mm-hmm.
what were your initial years? Did you actually, was chiropractor coaching or the training what you expected it to be?
I was kind of an open slate because I'd never heard the word until about 4 months before I went to school,
Right.
So I am a nerd kind of detective type mindset though. So I was reading philosophy books from the early developers as I was waiting for school and checking out things. So actually what I found was there's kind of two sides to chiropractic. One side is highly philosophical and kind of the wellness based, let's make you perform. And the other side is a side that's kind of followed a more medical type rubric where they're like, hey, you only treat people who are in pain or who have a complaint. If they don't have one, you don't need to see them. And I think both are necessary. And what chiropractic hasn't done so well is kind of blend the two, right? Because people don't generally walk in perfect health seeking to maintain wellness or
Yeah.
totally damaged. They're somewhere
Right.
in between, right? So but as I'm sure you experienced in medical school, the schools teach to the boards, not to make you a great doctor. So,
Correct.
you have to get through school, but you become the competent doctor by doing seminars outside, by doing postgraduate work, by reading, by doing the things outside of school that actually matter. And so I was thankfully into those things, and I've had great mentors along the way, and that's helped me get here today.
It's so interesting you say that. At the time that I went to medical school, I didn't think I was studying for the boards. I thought I was studying to learn the disease but eventually when it all comes down to it, it's really the MSQs,
Yeah.
right? Can you ace the MSQs? So let's say, so you finished the chiropractic school, and what was your journey into functional medicine? Like, did you ever practice like a traditional chiropractor, just, having the rows of those, what do you call those adjustment tables and just adjusting people?
Yeah, I did that because I went through chiropractic school without ever hearing the term functional medicine.
Right.
Because functional medicine isn't taught in any medical school, unless something's changed recently. But functional medicine is all postgraduate work. So basically, the chiropractic was my ticket into the game. And then once I had a ticket in, we all as doctors have to decide, well, where are we going to go? What's our niche going to be? What's our focus going to be? So I graduated as a chiropractor, began to practice chiropractic in the way that I viewed it as a wellness type thing, with implementing nutrition and exercise and stress reduction, those sorts of things. So I was kind of doing functional medicine without knowing I was doing it, and at a not as in-depth level as I am now. And so I did that until I actually came across functional medicine, and then dove in the deep end and went from there.
So for you, the journey was you were always about wellness because you were in the fitness realm, basically. Yeah. And so disease was not even in your radar.
No, not as, to me, so society tends to say, hey, disease is inevitable or normal with age, right? To me, disease was an absence of health, right? So like a shadow doesn't exist unless there's an absence of light, right? So we could say we are light, or health would be the light, and disease only shows up when shadows appear, right? So we could say, well, why is that shadow there? Oh, there's a wall between the light source and what's behind that wall, et cetera. So for me, the focus wasn't disease, or a different way to look at it, and this is where the chiropractic philosophy really fits in, is chiropractic states that, you know, there's a disease isn't an entity in and of itself. It's a lack of sufficiency, right? Or so, in other words, toxins or deficiencies are going to lead to the diseases or health problems. So the disease is a manifestation of you lacking something the body absolutely requires, like a nutrient or something like that, or you need to remove an interference or a toxin. So it's like, if you have a plant and it's sick, you don't say, well, it's normal for plants to get sick. You say, when was the last time we watered it? Have we fertilized it or given it food? Does it receive sun? Right. And if it does, we have a healthy plant. So it's kind of like, you know, we're all human plants.
Right. So once again, when you get into chiropractic practices, so the way I mean, growing up in the medical school, the traditional medical training, one of the things that I realized is I was taught never to use a chiropractor, right? I'm sure you've heard of that too, because we don't know what it is. And
we're quacks.
Yeah. I mean, I don't, in many ways, no, chiropractors actually do adjustment of the backs, but we were taught to tell patients, don't go to a chiropractor, it'll get worse. So I remember working at the VA, and I very distinctly remember there were a few patients who would come really sick and a lot of pain. There's a lot of pain, post-traumatic stress disorder and depression. And the ones who would go to a chiropractor after about 6 months, finally, when they get through all of that waiting list and get to see me, they were much better. And they will say, oh, my back pain was fine. And here I was setting up a neurosurgery appointment and an MRI and all of those things. And it just fascinated me. So I started getting curious about, you know, what do you mean you went to a chiropractor? And even then, at that point in time, I didn't realize this. And it was very funny when, you know, when I finally quit the VA, and one of the reasons I quit the VA, I said, I've been seeing these guys for 10 years. And the federal government is very rigid with its standard guidelines, right? A diabetic needed to be on this many medicines. A hypertensive needed to be on these medicines. We got to start with hydrochlorothiazide. We got to have a beta blocker if they had a coronary artery disease. So I was doing what I thought was guidelines. I was meeting the guidelines. And all I realized was I was meeting the guidelines. The guys were seeing me on a regular basis every 4 months, and they were getting sick every year. Like I added new medicines or new diagnoses. And at some point, I didn't know what else to do. I wasn't necessarily aware. And when I finally, when I quit, I started my own practice. And I had my first office where I subleased in an occupational health. And the occupational health is what they did was they did physicals, I guess, pre-employment physicals. And then they would do like if work injuries, workman compensation injuries. And I remember talking to one of the doctors there, and he was saying, oh, we were just discussing about back pain, and it says, oh, I send them down to so-and-so Dr. Stiles or whoever was down the road, and he's a great chiropractor. And I'm like, oh, really? You send people to chiropractors? I know, totally. Because all I did when back pain was go to physical therapy. That's what I knew. Do extra physical therapy, doesn't work, then go to the neurologist or neurosurgeon, whomever I felt was the right person to go. And this chiropractor in between, I didn't know what exactly their role was. And it was just so weird. A week after I had this discussion with this man, and I had taken the card of the chiropractor because I was getting a lot of women with low back pain.
Yeah.
And I wasn't planning on doing anything with it, but I had this card. And a week later, I actually got up in the morning and I couldn't get out of bed. I had no freaking clue what had happened. I just knew my back was in real spasm. I had severe neck pain. I hadn't done anything different. I was exercising like I normally did. But over the last few months, I had started having a lot of aches and pains, particularly in the neck. And I remember it was like something like 7 a.m. And you know, when you're in practice, you don't show up, you don't get paid, right? When you're a private practitioner. So I remember telling my husband, you know what? I don't know what I'm supposed to do. I have no idea. It's just like my back is severe. But this conversation came to my mind. And I said, there's a chiropractor just down my home, the practice, everything was in the same place. I said, I'm just going to give him a call and see if they will see me. And they said, yeah, sure, come on. And I remember my husband had to carry me in because I just couldn't walk. And I walked out of that place.
Yep.
With absolutely, I mean, I would say there was residual pain was there, but no, I mean, literally nothing compared to what I walked into that office.
Yeah.
So that was my first experience. But I would say this, he said, he did x-ray. And of course he said, you know, I think you need some adjustment. And, you know, I didn't think I had any DJD, even though he may have said something about a bulging disc. Mm-hmm. But something that he said is, he said, you need to look at what is actually causing this. Mm-hmm. So coming to that, when as a chiropractor, and then I started reading about the spine and how the nerves connect to the internal organs. Mm-hmm. And how sometimes when you have a back pain, it may not be the back as such, but it's telling you something about the internal organs. Can you explain a little more about it? Because I'll tell you how my story ended after you tell me what, I guess, how you're taught about that.
Yeah. So basically, chiropractic views that the nervous system is primary. And mm-hmm. so, you know, the brain communicates with every cell in the body via the spinal cord and out the spinal nerves. And if you look at spinal anatomy, there's a sensory branch and a motor branch of every mm-hmm. spinal nerve that leaves at every level, right? So the sensory branches go to joints, skin, muscles, mm-hmm. and organs, and then the motor branches go to muscles. Joints, etc. And so what can happen is a back pain could be a true back pain, like you had an acute injury, and that's a true somatic issue, right? But you could also have a somatic issue that is caused by an organ or viscera. So it's a viscerosomatic referral. So say you have a diverticulitis, and it's referring to the low back. So you have low back pain, but it's because, you know, you have a diverticulitis flare because you ate, you know, some flax seeds yesterday, and now you have back pain. You could also have damage to your low back that causes an organ issue. Okay, so it works both ways. That would be a somatovisceral reflex or a viscerosomatic reflex. Mm-hmm. And so, for example, I've had many patients who come in with low back pain who that's all they complain of. Mm-hmm. But after a couple adjustments, they say, you know what? I used to get up all the time every night to go to the bathroom, or I've had diarrhea for years, and that's cleared up since I started to come see you. And so it's by adjusting their low back, we're normalizing the nerve tone, and so there's no longer that irritation to the nerve, which results in end organ irritation, which results in diarrhea for that specific person, right? So it's kind of like we were talking off camera. Just do what you do, create health, and the body takes care of what needs to be taken care of.
Right. So for me, actually, after the adjustment, obviously, I had to treat myself. And what do I go for? Prednisone, right? Mm-hmm. Because I needed to function. I was covering the week in the hospital. And a few months into it, the neck pain got really severe. I mean, I was going to physical therapy, getting traction, getting adjustments. And I, you know, I started having other health issues besides the fatigue, and really what it to just shorten my story, was I had Hashimoto's.
Mm-hmm.
And it was so funny when I started treating her. That's how I found functional medicine, because I refused to get on the thyroid medicine that early in my life. Though I have a predisposition to have Hashimoto's. My brother had Graves, my mother had Hashimoto's, and I was like, I don't want to take medicines. Graves, I know, happens really in the younger patients,
Mm-hmm.
but I didn't want to get on a thyroid medicine. And when I found functional medicine and I actually worked on my gut and, my health, actually, I've never had a neck pain.
Yeah.
And it's just so fascinating. I always say this to people, but I don't think people make that connection. When they have back and neck pain, they truly believe something needs to be done. I have a bulging disc,
Right.
and they get this MRI, they get this erroneous diagnosis. So now when chiropractors say, you need repeated adjustments, what are they actually referring to? Why do people need repeated adjustments?
Because most people don't come in right when the problem starts, right? Unless they have that acute issue where they can't go to work. Now they're going to come in, right?
Right.
But just like that's where they go to prednisone. What's going to get me back to work right away, right?
Yeah,
So if an issue is chronic but they can function,
mm-hmm.
They're not coming in for a few months, or they're going to see their GP and their PT first, and if that fails, then they'll come see us, right?
Yeah.
And so by then they've got neuroplasticity in terms of if there's any peripheral sensitization or central sensitization, which is for the lay people listening, if the nervous system learns a new normal, like, hey, your low back muscles this tightness is new because this is to stabilize and protect you. This inflammatory level is now your norm. Well, now we have to undo that, right? So one adjustment isn't going to undo the 3 months you've just built up.
Okay.
But then one thing I would say is, like every profession, there's different knowledge levels in different doctors that you see. So as a patient, you have to figure that out. So if you've had chronic pain and you've been being adjusted for for months or years and nothing's changing, then you probably need to see someone who's going to investigate deeper and say, well, maybe this low back pain is a viscerosomatic thing. Like, do you have any inflammatory bowel disease or IBS or, symptomatology that goes beyond just the surface pain? Is there a organic cause, right? And one thing I would just touch on is, healthcare is a free market. So just because you've seen a doctor and you may even have a good relationship with a doctor, if you feel like you know more than them, you should probably go find another doctor. Doesn't mean you can't be cool with those people and when you see them out and about, but your health, you get one shot at this. And so once you've exhausted one doctor's knowledge base, that's not to say they're a bad person, but you may need more. And if you're not getting more for yourself because you don't want to offend somebody, then
No, we always say this, right? People lose decades before they come and find the right doctor. And a lot of times, like you said, it's loyalty. Secondly, it's also the knowledge that this is medicine. Like, this is the person I need to go to when I have a problem. And if all the experts say there's nothing that can be done, then that's the truth. Nothing can be done.
And
right?
one thing I'd say to that is, you said you were taught in school, don't send them to a chiropractor because they'll get hurt. Well, if you're interested in history, the mainstream medical profession is famous for trying to dominate and have the monopoly. Right. So like they took osteopaths and they absorbed them. They tried to destroy chiropractic, and chiropractic actually won a Supreme Court lawsuit against mainstream medicine in the 70s, because of this. So that them teaching you guys to not send to us has financial bias behind it, has monopoly bias behind it. Like, there's a market. Healthcare is a market and an industry. So the patients out there have to understand that it's not always their best interests that are first. It's, because if it was, they'd be trying to heal you, not Band-Aid over symptoms with drugs that you then take forever. And like you said, you're at the VA and over 10 years, you're just adding diagnoses and drugs. If the goal was healing, the protocols you were following would not have been the protocols you'd be giving, right? And you've learned that over time. Yeah,
I know. It's like the key thing, and I think the key thing is people need to understand if something is not happening, you're going, but again, let me tell you this. This is where I think we're getting into an issue with what is normal. I go to my doctor, I have a problem, they give me a medicine, the problem gets immediately better. It doesn't have to go away, but it gets better. My sugars were 500. Doc put me on metformin and gave me Januvia. Now it's 80, and I can still continue to eat the way I've always been eating. Then my stuff got better. Nobody ever talks about it got resolved. And we don't compare it to calling a plumber to your house to fix the same pipe over and over again every 3 months.
Right.
I know we wouldn't do that to our home, but we are okay with doing it to our bodies because we think there is no other option.
Mm-hmm.
And a lot of times when people come and tell, my doctor did all the tests. And right there, I'm sure you've heard of that.
Yeah.
And it's like, did they do the right tests? And I think that's where that's one of the things that I wanted to talk to you about, because I didn't have an OB-GYN for this topic of female infertility, because I've seen if people don't know and have not followed Dr. John Bartemus on his YouTube channel or even on his Facebook, he does wonderful videos. And these videos are very informative, and they're like less than 15 minutes, but a lot of information that you put in. And I just realized, a lot of OB-GYNs also, I've watched a lot of videos on infertility and read a lot of papers. They focus on the main things about, the pituitary failure, the ovarian failure. And yet I think when you look at the infertility information, it's about 10% don't have an answer. Everything seems to be normal through their investigation. And for that 10%, I don't know if it's bigger than that. In your experience, do you see a lot of women who come to you with infertility, or do they come with other issues and then infertility is just one of the problems that get resolved?
Yeah, I've seen both. Seen it both ways.
Okay.
So multiple that, hey, I'm coming because I'm infertile and I failed IUI, I failed IVF, and like no one can help me. And then I've also had patients who came for, say, psoriasis and then got pregnant and then told me, hey, I've been infertile forever. I just thought I was, so
nothing could be done.
Yeah, because they've accepted what they've been told, right? And so I see them from both angles, and in both instances, there are things to be done. So again, this goes back to if your doctor lives in this box and these are the only possibilities that could be contributing, once they've exhausted those, then it's like, well, it's all in your head or you're normal or whatever. Well, no, you need to find a doctor that has a bigger, box full of possibilities and can look deeper. And so that's what I do as a functional medicine doctor, is look for, hey, are there hormonal causes of your infertility? Are there autoimmune causes? Are there toxicity causes? Are there organic causes? And then how many different causes do you have? Because every patient's a different puzzle. So you're probably going to have more than one cause because you're a human. You're not a textbook.
Yeah. And that's actually probably the biggest challenge is people don't realize. I was just looking at the statistics, and I'll tell you, 2014, I think the latest statistics, I'm sorry, my phone keeps ringing despite me shutting it off. So I'm not doing a good job with that. So in 2014, they had 190,000 cycles initiated through these, what we call the assisted reproductive technology.
Sure.
And in 2016 was 263. So it's like 25% increase, and I'm sure it's much more now. And there were about 76,000 infants that were born through this ART, the assisted reproductive. So infertility is actually a growing problem. Though right now, if you go to the CDC, it says like less than 1.7 or 1.9. So about 2% of the population probably struggles with it. What has been your experience when it comes to infertility? Is it mostly men or women, or do you say they're equal?
What I would say is, at least perception-wise, it's highly biased towards women. And when I work with someone or a couple, I always tell them, hey, I realize you're coming in female for this, but if there's a likelihood that we may have to check him out, because it takes two, right? And so if you've been through IUI and IVF and the husband's never done anything, in terms of giving a sperm sample and been checked that way, then it may be all in the husband or a little bit of both of you. And unless you address the whole picture between the two, then you may not get the baby you desire. So at least perception, it would be females. And I think that's unfair and inaccurate because of, you know, some relationships end because of that. Some women walk around thinking they're broken or low self-esteem or whatever because they can't have a baby and that's all they ever wanted. Well, first of all, as we've discussed, they probably haven't been thoroughly checked, and then it's highly likely that the husband or the partner's never been checked. So that needs to occur.
Do you actually see that where because usually I see when infertility is an issue, both of them get checked, but I think with the guy, they just do sperm count and motility. And I think that's pretty much what they do with them.
Yes. So the ones that have been checked, they do the sperm sample and they're looking at, like you said, the count, the motility, and various different markers. And even if they're off, it's like everything in medicine. They'll have a lab high or lab low, and then the guy's like, "Oh, they said that I'm normal." And I'm like, "Well, you have lab abnormals on the sheet,
right?
And, you know, motility's off. That could be because of infection or this or that or heat or EMS or that sort of thing." So it's, yes, again, what is normal? Like you started saying earlier, normal in the conventional model is not normal in the functional model.
Correct.
So understanding the paradigm that the normal came from helps you understand if you're truly normal or not.
Right. So let's say when a female comes to you, normally what has she really undergone before she says, you know, infertility is a huge issue. I've heard you've helped people. What have you seen that most of the times gets missed?
So let's just say a typical avatar would be someone's coming in. Excuse me, I need to cough here. Excuse me. Would come in and say, "I have infertility. I've had X number of miscarriages. We've done everything like cycle maps and ovulation predictor kits and all of that. We've even tried IUI and IVF, and you know, they say if I fail one more, I'm done." Okay, so before we do that, what can you do? Save me. You know, It's like, okay, awesome, thanks. Excuse me. So that is what's typical.
Yeah.
From a presentation standpoint, and then if you're asking, what do I end up finding? That varies as well, and we can go through certain.
We'll go through
if you want to.
Yeah, absolutely. We'll go through that. So let's say, so when you look at the traditional definition of infertility, they say it's like 12 months. They have tried to actually get pregnant, and they've been unsuccessful. Because usually within the first 4 months, your success rate is 25%. It's almost 80% by 6 months. So if you go to a year and you've really not had any issue, you know, chances of getting pregnant or did not have any pregnancy, there are two different types of infertility, right? You have the primary where they never get pregnant, and the secondary where they get pregnant. I would say in secondary, I would call it two also. It's not like usually secondary is when you've had a child and then you can get pregnant again. But I also think there's in between this, I see a lot in doctors who do residency is getting pregnant but not being able to keep the pregnancy.
Yeah.
Right? And the miscarriages, I don't know where they've fallen, but I think that's a very devastating aspect. My example would be I had 6 pregnancies. I've only 2 live children. So, and at that time, I didn't even think about it. Now I know why, but I just thought it was the stress of pregnancy, stress of residency, and, you know, I'm just getting used and trying to do all the right things. But I think that's a huge part. So in terms of people, do you see a difference in the avatar where people are not getting pregnant at all, the ones who miscarry and the ones who've had a pregnancy and then are unable to conceive again?
Yeah, I think, at least in my patient base, the most common one is it'd probably go the person with miscarriages first, and then the person who can't get pregnant, and then the person who's had a baby but can't have another one. So those are probably the least that I've seen. Mine tend to be the can't carry through as the most, and then, hey, we can't get pregnant at all as second most.
So in that part, like the ones that miscarry,
Mm-hmm.
I'm going to ask you, because you're coming from a functional medical perspective, and I can tell you what had been my experience.
Mm-hmm.
But what have you seen was done for them in the traditional medical world before they come to you? Like when they say all the tests have been done and nothing has been found.
Mm-hmm.
And how many pregnancies does it take? How many pregnancies do they have to lose before they say, you know what, I got to go to a person who has a different way of thinking?
It's multiple, you know, probably 3 on average from the people I see. And what they've had done would be, you know, maybe some hormone testing, which is even the hormone testing being done is incomplete.
Right.
You know, they may have even tried IUI or IVF already, and been successful but not carried. Or go ahead.
Do you want to explain what IUI and IVF is?
Yeah. IVF is in vitro fertilization, and IUI is intrauterine insemination, implantation.
Yeah,
Excuse me.
Yeah.
So basic. Go ahead.
No, go ahead. So they would have tried those two. So do they try those two with miscarriages, or do they just miscarry, and just decide, you know, they need to have a different approach?
It's been a mix.
Okay.
Yeah, it's been a mix. So I you know, I don't get to choose. They come to me. So
right.
But it's been a mix. It's probably with miscarriage more. No, I'd have to say it's been a mix.
Yeah. Okay. Yeah, because I would have, you know, when I miscarried or had ectopic pregnancy, I never thought about, you know, the possibility of me not having a baby, probably because I had a very logical explanation as to, you know, why I was miscarrying or having ectopic pregnancies. So, so when a woman comes to you, so usually it's multiple. Do you? Does she come to you for that specific issue, or is there other underlying issues she's just given up that she can't carry a baby to term? And would that be what has been the profile? When I'm trying to figure out, when does a woman say, hey, I've had 2 miscarriages. The traditional gynecologist doesn't believe there's anything else. I'm still young and I can still get pregnant, but which is what they tell you, right?
Yeah.
Don't worry about this. You'll get pregnant kind of thing. Just have a 6-week gap or another 2 months gap, depending on if they do a DNC or not. What would you say should be their approach? Like, hey, you've had 2 miscarriages. They don't have an answer. What is that saying? Trying to do the same thing over and over again?
Insanity.
Yeah.
Einstein.
Right.
Yeah. So I would say, if they're not presenting directly for the infertility, then the next thing the listener should question is, again, conventional medicine is very myopic, very specialized, very focused. So they're only going to consider your uterus and your ovaries, right?
And the pituitary axis.
So the hypothalamic pituitary ovarian axis.
Right.
But you need to ask yourself, what else from a health standpoint is going on? Because at least in my experience and the patients I've seen, oftentimes these women also will have psoriasis going on, or Crohn's going on, or Hashimoto's going on, or family history of endometriosis, or very high stress, or PCOS, or insulin, you know. So what other metabolic issues systemically are you dealing with? Chronic infection, you know, what are you exposed to? All of these things matter, and there's defined scientific mechanisms by which these various things can be causing your infertility.
Yeah. So
that your OB is never going to consider and probably has never heard of.
And you know, that's the part, I think that's the 10% that we're going to be talking about, right? So when an OB or gynecologist, even if you look at all of the studies, they talk about infertility as, hey, your hypothalamus is not producing a hormone, the gonadotropin releasing hormone, or there's a problem with the pituitary, is either producing too much of prolactin or not enough of the follicular stimulating hormone or luteinizing hormone. Or it could be a ovarian problem where there is like the type 2 ovarian failure, which would be your polycystic ovarian syndrome, or it could be that you're not having enough follicles, the premature ovarian failure. So they kind of create this is why you have infertility. And this is the only axis that they look at, right? So they look at the prolactin, they look at these hormones. Sometimes they don't even check the prolactin, because if they check the prolactin, they would have to check the thyroid.
Yeah.
And a lot of times only TSH is done, which is actually, once again, a pituitary hormone. It's that's the other part of it. So let's look at the broad classifications of what are we missing in the 10% of the women who come in with infertility. What do you say? What would you say is like one of the commonest things that you see over and over again that the traditional medical system is not looking at?
Yeah. Immune dysfunction would be the broadest answer that I'll say. So some level of immune dysfunction, and then depending on the female, this person, the immune dysfunction may be autoimmunity. This person, it may be chronic infection. This person may be endocrine disruptors or stress or cortisol that's suppressing immunity and suppressing sex hormone production. Insulin resistance is a huge one as well. So blood sugar abnormalities. So real quick though, you mentioned kind of the box or the differential list that they live by. Well, one of the things you said was premature ovarian failure.
Right.
Well, that could be an autoimmune driven. Their premature ovarian failure could be autoimmune, and the OB is not going to consider that most of the time. And so again, if you have an autoimmune issue going on that may not be diagnosable yet, but is still happening in your body, then if they don't know how to look for it, or if they're only going to call it that when it meets diagnostic criteria, then they're going to miss it for years or forever,
Right.
So
just so you to explain what autoimmune is, I'm sure many people who listen to our podcast do understand what autoimmune is, but what would you say is autoimmune? What does autoimmune mean?
Yeah, so autoimmune means essentially that your immune system is forgetting the difference between Dr. Nisha and not Dr. Nisha, right? So where it would fight strep in the past and leave Dr. Nisha alone, now it sees strep and parts of Dr. Nisha that look like strep and attack them both at the same time. So now Dr. Nisha is being damaged by her own immune system, so autoimmune disease. And so the tissue being involved, so you said you have Hashimoto's, that's thyroid autoimmunity. So Dr. Nisha's thyroid is being attacked by her own immune system because it's lost tolerance to self, or it's lost the ability to say, hey, that's Nisha, don't shoot her. That's strep, shoot that, right?
Right. And this is probably another good way for people to understand. When you have a disease process, when in the traditional medical system, let's say for Crohn's, or for that matter, even psoriasis, when we're trying to give what we call the immunomodulators, I always tell people they're not necessarily addressing the disease. They're basically attacking you.
Yep.
Even our treatment gets down to attacking the person. And that's why when you're taking something that is modulating your immune system, and I don't know if patients get explained this, the first 5 years you're at a high risk for infections, the next 10 years are at a risk for having cancers, so that you don't have the joint pain and it doesn't completely go away. Because
the Humira commercial,
Right.
And the way I explain it is, first of all, it's never being explained to them properly, because the immune system is very complex. So my metaphor is the immune system is an orchestra, right? So you have stringed instruments and brass and percussion, and each instrument is a different pathway that has different responsibilities. Well, the medical system has 8 minutes to deal with you. So instead of teasing out which instrument in the pit is not playing well, they're going to give you a Humira, which drops the curtain on the whole show.
Yes.
Okay. So instead of figuring out, hey, percussion's off, let's just nuance that out and deal with that specifically, we're going to just drop the whole curtain, and sorry if the crowd's mad, but that's it. We're closing the show down. And by dropping the curtain, that's why you have increased risk for TB or cancer or these things, because not only is it stopping theoretically what's causing your issue, but it's shutting down all the functions that you need that weren't a problem.
That's a very nice way of explaining what we do when we just throw them with drugs. I know they're trying to now figure out, can we get just one that will go to the specific cell or the specific immunity? But as they've, like I always say, if you don't know what the problem is, don't try to formulate solutions.
Right.
Because the solutions are going to probably be completely wrong. Right.
Right.
So let's say you said immune problems. Women come to you mostly with immune problems. So we mentioned autoimmunity. What kind of testing do you get into to discover what kind of immune problems they might have?
I'll get into the testing that they need is the ambiguous answer. So
yeah,
I'd work up the female specifically, but in your case, for example, if you came in and you said, hey, my father had Graves and my brother had Hashimoto's?
My brother had Graves and my mother had Hashimoto's.
Okay, sorry. So family history of thyroid.
Yeah.
So, the thyroid antibodies would be something very important to test. And the typical conventional model is going to run a TSH and maybe a free T4. A full thyroid panel is going to be 9 markers. So if you've seen your OB and they said, we can't find it, we don't know, and they've only ever run 2/9 of a thyroid panel, they can't say it's not the thyroid because they've never actually asked every question, right? So a full thyroid panel would be big time there. And excuse me, in any infertile patient, thyroid's important because whether or not you have autoimmunity, thyroid hormone T3 promotes luteal cell production of progesterone. So your thyroid and your progesterone are interconnected. So you may be infertile because of thyroid dysfunction affecting your progesterone levels and your ability to ovulate and conceive, etc. So thyroid's very important to check no matter who you are and check thoroughly, which isn't happening in conventional medicine.
Right. And then a lot of times we have to understand in Hashimoto's, just like what Hashimoto's is, the thyroid is getting destroyed, but somehow the body is able to function normally till the thyroid gets completely destroyed. So you will have high days and low days. So some days you're going to have palpitations, lots of energy, and feel good. And other days you actually feel lazy. It's not even fatigue. It's actually a laziness, no drive to do anything. Having experienced all of this, it's something that I understand when women come and tell me, I don't know, I used to be fine, but I still think I'm fine, but my husband thinks I'm lazy. That one of those changes in the personality. And that's why when you do a test at any given time, the TSH will be normal. The T4 can be normal because you're doing it on a day where you're not having the high or the low. And again, you're missing that window, even if you're trying to diagnose it with just 2 of those tests.
Yeah, absolutely. Because you could have a normal TSH and normal T4, but your T3s are in the tank.
Yeah.
Or even your T3s could be normal, but you've got raging thyroid antibodies, meaning the immune system is attacking. And so that's what you need to understand is in Hashimoto's, the thyroid is the innocent bystander. That's the tissue being damaged, so that's their focus. That's why they give you Synthroid. But the real problem is the immune system attacking self. So if we give you Synthroid and just walk away and don't address the immune system and the drivers of that process, then you're never going to get better. Right.
I just recently had a young woman who showed me her thyroid panel, and her TPO was 2,690.
Wow.
And she has this hoarseness in her voice, in her throat that never goes away. And they've done, ENT has scoped, and they said, there's nothing there. Everything is fine. And she said, is there something in the thyroid that needs to be addressed? And her doctor said, we don't do anything with that. You're fine. You don't need thyroid medicine. But actually, she's experiencing inflammation and actually dysfunction. And she's almost being told by the experts that that's fine. Your labs are normal, right? So I think, once again, people have to start thinking, if I am struggling with something and you tell me my blood tests are normal, there's a disconnect here.
Yeah.
And I don't know how many different ways we have to explain to people that if you have a symptom, we did not find it in the testing we did, then we need to change our testing.
Correct.
Or we need to do more testing, right?
Yeah, the problem is in our culture that the blame falls on the patient in that instance, not on the doctor. So they say, hey, we did the testing, it's normal, it's all in your head. Here's some Xanax or something, right? And it's doc, you either need to test more deeply, learn more, or patient, this is what I was talking about earlier. You're in a free market. You need to go find a doctor with the knowledge that can help you and isn't going to brush you off and say it's in your head. If they're saying that, you've reached the limit of their knowledge and you're done there. So you need to go find a doctor that knows more, or else you're going to get that insanity. You're going to keep getting what you've always gotten and get the same results, which are poor.
And that's a very important point you said. You've reached their maximum of their knowledge level. Physicians who actually listen to functional medicine, I mean, a lot of times I see it among physician groups too. When I'm in traditional physicians and functional medical physician groups, one of the things I see among traditional physicians is how quickly they will come to the conclusion, yeah, you got to get your thyroid out so you can get pregnant because, you got the toxic nodular goiter. Yeah. And a lot of times it's almost like it's not even their knowledge. I think as physicians, we have to make that change. I don't think we ever stop learning, number one. We shouldn't traditionally, but our continuing medical education is really geared towards what is the latest drug, what is the latest testing, and what more can we do to diagnose things early. It's never been about how can we get patients back to wellness, or why is this happening and why should we get to that's not even the philosophy in medicine.
Right. 100%. And if we go back to looking at it as an industry, right, a well person makes the industry $0. So that's why everything's focused on the next drug or the next test, because that's what they bill for, right? So again, as the patient, you have to advocate for yourself and say, your goal should be optimization. And I say optimization instead of cure because matter has limitations, and there's certain people that'll never be cured, but they don't have to live with the same crappy quality of life that they have right now. They could have their health optimized by someone who can do the detective work and go say, hey, we clean up this, this, and this. You're never going to be 20 again, but you can not feel like you're 60 when you're 40,
Right. So thyroid is one of the main issues, and I totally agree with you. Hashimoto's. What are the other antibodies that you would be looking for if somebody let's say they don't have Hashimoto's?
Sure.
What are the other things?
So if you're a woman that's been told you have premature ovarian failure, you want to look at ovarian antibodies, because if you have antibodies directly to your ovaries, well, then that's going to damage the ovaries and your eggs and look like premature ovarian failure. So, and I've had patients that have this, and I had a patient that had infertility, hard time getting pregnant with her first, and then we dealt with this, and then she had her first, and then she had more after that. So understanding, and ovarian antibodies are something that most even functional medicine doctors don't know about. So those could be there. Also, antiphospholipid syndrome is another one you want to look at. And antiphospholipid syndrome has been associated with birth control pill use. So the more and longer that you've used birth control pills, the higher your risk of autoimmune disease, period, but antiphospholipid syndrome specifically. And so if you have antiphospholipid antibodies, that means your immune system's attacking the phospholipid bilayer of cells. And so if you were to conceive and those cells are expanding, the immune system may attack that fetus as enemy and prevent, carrying through.
So just go back to the ovarian antibodies. What is it attacking? Is it attacking the ovaries or the ovum, the follicles, or what part of it?
It's attacking the ovaries.
The ovaries.
The ovaries,
and do they actually see it in traditional medicine? Like, do they look for ovarian antibodies or no?
No,
they don't. Okay. No. And it's the same way, like with any autoimmune condition, you just address it from the root cause.
Yeah, you want to check out, address their orchestra, right? And whatever's going wrong there, but then also looking at the rest of their health picture. So how's their nutrient status? What's their blood sugar like? What's their hormone stress, toxins, et cetera, et cetera. So their complete puzzle needs to be addressed. But obviously, if there's autoimmune process, the immune system is going to be the primary thing that is the priority.
Our focus should be on how to reset the immune system.
Yeah.
Or retune it and figure out why it was out of tune.
Yeah, and so another thing, that can cause it to be out of tune is if you have chronic infection. And so whether you have a chronic infection locally or systemically, that can result in infertility, specifically as pelvic inflammatory disease. So if you have PID or pelvic inflammatory disease, that's been shown in the research to cause preterm labor, cause miscarriage, and cause endometriosis. And so if you have a chronic infection that is not showing lab high in your WBC or your white blood cell count, again, your doctor's not even going to think about it or recognize it because it's not acutely obvious. Okay, so Epstein-Barr, common one. Cytomegalovirus, common one. Human herpes virus 6, common one. And all of these are associated with chronic fatigue and with other symptoms that, doctors could brush you off and just say, we don't know, or you have fibromyalgia or something like that, and just push you out the door.
Okay, so you actually look for systemic viral infections. You're not talking about infection in the uterus?
Correct.
Okay,
yep.
So systemic yep. viral infections. So that's one. So you have autoimmune, you have indolent infection that's not very obvious and nobody's looking for it.
Yep.
What are the other conditions why infertility is an issue?
You want to look at your toxic exposure, and the average woman uses 12 health and beauty aids per day, okay? And the average male 6. So the average female is using 12 products per day, shampoos, makeups, deodorants, lipstick, etc., that contain endocrine disrupting chemicals. So you can read the label and say, hey, are there phthalates or parabens or dioxins or glyphosate or BPA? And if those are there, those are all endocrine disruptors, which are all estrogenic or promote estrogen, which if you're using a lot of them and becoming estrogenic or endocrine disruption, you're going to sway that hormone balance, which then could lead to infertility. That's one way of many. So toxic exposure. So looking at your stuff in your household in terms of health and beauty aids and say, hey, is this clean or is this full of toxins? And another
but the clean ones then just don't stick to your face.
Yeah, but
right.
Do you want a baby or do you want to?
I know.
But another thing to consider too is that the health and beauty aid industry is deregulated. No one's checking that. Yeah. So many products, it's known that many products contain estrogen directly in them that is not reported. So that in and of itself will skew your hormone profile and potentially lead to hormonal imbalance that could cause infertility.
Yeah, actually, simple stuff like over-the-counter lotions actually have estrogen in them, and a lot of people don't realize, especially men putting it on. I think they need to be aware that these do have estrogen. So, toxins. So, how do you know if you are toxic? Do you do a specific testing for that, or do you just go?
Yeah, there's testing that you can do for it. And I don't do that on everybody. I don't do anything on everybody, but when I'm working up the case, there's certain questions in my questionnaire and things that will point me that way. And for example, I can tell you I've had a patient recently who works on a farm, and we talk in our consultation that her husband is married to Monsanto, right? And they're spraying glyphosate like crazy. Well, glyphosate's been documented to be probably the strongest associated contributor to type 2 diabetes development beyond diet and beyond sugar and all of this. So toxins may be the answer in a given case. And so testing is important in certain cases. I don't think everyone should be tested, but again, that's the clinician's acumen should lead them that way.
Yeah. So once you discover that like they have toxins, do you do like a detox protocol? Do you like particularly things that when you read about infertility, mercury can also be a huge part of the infertile profile. Yeah. And people eat fish on a regular basis, right? Everybody thinks fish is very good, so they start eating it 5 days a week without understanding.
Yeah. And so they're eating the fish, and then they have like 15 amalgam fillings in their mouth that are off-gassing, 15 micrograms a day, so that the tissue load builds up quickly. So, finding a doctor that can find out whether or not that's contributing to your case is key. And then, excuse me, if it is, then in the case of amalgams, you need to work with an environmental dentist to help you do that properly to get those out and converted.
Okay. And usually after you address the toxins, do people like actually see a difference in their health? I mean, I'm assuming you're addressing toxins. It's again very multi-pronged approach, right?
Yeah.
You got to address what do you normally do? Okay, you looks like from your history you got this exposure to chemicals, like somebody who's a hairdresser or somebody who works in a salon, right?
Yeah. So first and foremost, you have to do your best to avoid any and all exposure, because we're not going to ever be zero exposure. But if I'm a female using 12 products a day, what are the 3 you have to have, right? You know, so for your vanity, right?
Yeah. Gotta have the mascara.
Right. But you have to reduce exposure. That's the biggest thing, because if you continue to put it in, you know, what are we going to do? And then it's supporting healthy clearance of toxins. So your liver, your gut, and your kidneys are your 3 main detox organs. So making sure those things are all working optimally and in unison. And then, you know, looking at foods and your air and soil quality and all of this stuff. You could go on scorecard.org and punch in your zip code, and it'll show you how your town ranks in air quality and soil quality and water quality.
Oh, really?
Yeah.
What is it called again?
Scorecard.org or .com. It's one of those, but it is Scorecard.
Okay.
So that can show you, hey, you know, Charlotte, North Carolina is one of the worst blah 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 in water quality nationwide. Okay, well then maybe I need a whole house water filter, you know, that sort of thing. And then can I change subjects quick?
Yeah.
So I think any functional medicine webinar would be incomplete if we didn't mention potential genetic SNPs.
Yeah. I was going to come to that after the toxins. Yeah. So genetic SNPs.
I also definitely consider that because there is in a genetic SNP stands for a single nucleotide polymorphism, which means a mutation that may lead to, you know, something you don't want, right? So common right now, or sexy or hot topic, is the MTHFR gene, and it's important for fertility and for fetal development because it requires folate to function, and folate is necessary for neural tube development, or the baby's nervous system development. So if mom has genetic mutations that make her inefficient at MTHFR function and folate function, then she may not, or the fetus's nervous system may not develop properly and may be aborted or may be born with certain issues. So this is why, you know, pre-testing is important, but also the right prenatal vitamins are important, because it can easily be dealt with if you have it and you find it by using the right form of folate, which is not folic acid, but is methylfolate. So that's something that, you know, there's a genetic contribution, but the genetic contribution, first of all, is not a damnation to it happening. It's just a potential for it happening. And then secondly, the genetic contribution really can be dealt with by making sure nutrition-wise you're sufficient in what it needs to function optimally. So just because you have the gene doesn't mean you're damned to it. We can just give you some methylfolate, how much depends on the person, and bypass that little hiccup.
You're right. So that's something that, in fact, I think when it came to my history, I really think that was the main issue. I have COMT is completely out. And I didn't know that for a long time until I did my genetic testing. And it does have the key thing about infertility, and I think what most people don't realize is it has long-term implications for your chronic health. And one of the biggest topics that we didn't even touch is the polycystic ovarian syndrome. And I think that's a huge part of infertility. And within polycystic ovarian syndrome is another whole aspect of other metabolic abnormalities that you can come upon, which can be addressed too. So how many of your patients have you actually, and usually people who come with polycystic ovarian come to us with, hey, I've been diagnosed with PCOS, like it's a badge of honor, right?
Yeah.
And I have PCOS. So how many of that, do you see a lot of them with?
I've had a few that have known or diagnosed PCOS, but I've had more that have, say, androgen dominance that maybe don't fit PCOS diagnostic criteria yet, but for all intents and purposes, metabolically, that's the way they're going, right?
Okay.
So, you know, there's certain diagnostic criteria to be called PCOS, but a person's physiology can be trending that way before they meet criteria. And so why let them meet criteria? Let's catch it and turn it around before that, right?
Right.
So, so I've seen more of that, and one of the major drivers of PCOS is insulin resistance. And so if someone's got insulin resistance, or someone's got infertility, but their blood sugar isn't well regulated, specifically along the lines of insulin physiology, then that may be the ticket for them. So I tell patients, you know, there's 4 pillars for hormonal dysfunction that we want to observe before we're giving you a testosterone injection or an estrogen patch or whatever. We want to look at what's your blood sugar regulation look like, what are your systemic inflammatory levels, and in there is all the immune stuff. So is there autoimmunity, is there chronic infection, etc. What's your liver's ability to detoxify, and what's your gut health look like? Because if you have one or all of those off, then that could be driving your hormonal imbalances, and in the context of this webinar, your infertility. And so again, your OB is never going to look at that stuff. So those are things that maybe it's insulin resistance. So we improve your insulin sensitivity, and there's a million ways to do that naturally. You may get pregnant, you know, and you don't have to go spend $50,000 on an IVF. Just give Dr. Nisha 10,000 and you're good, right?
I wish.
So, you know, so it's these are the things that people aren't thinking of, that if we can find them, it's relatively simple to deal with. And then it's like, man, why didn't I find you 5 years ago, doc?
Right,
you know?
right. And a lot of times insulin resistance is not necessarily diagnosed. Like I have people who I call the skinny fat, where they look very normal on the surface, but when you get down to getting their questions, the questionnaires, as well as their testing, you actually can see the insulin resistance, and that never gets addressed. For instance, you have a fasting blood sugar of 90, perfectly fine. Your A1C is 5.3, very good 90-day average, but your insulin is 55 in a fasting state. You have resistance. For some reason, your body is having to do 10 times the amount of insulin to keep your blood sugars normal, but nobody ever checks insulin. I don't think even an endocrinologist checks insulin levels in a fasting state.
Right. And what that tells you from a broad perspective is if your receptors are resistant to one hormone, you're likely have some level of resistance to others. So there may be some thyroid resistance going on. There may be some cortisol resistance going on. And then there's probably some FSH and LH resistance, which could affect fertility. Right. So, and another indirect way. So, you know, it's once the body goes off, and insulin, I mean, blood sugar regulation is one of the fundamental keys to physiology. So if you're insulin resistant, I mean, there's a whole bunch of downstream things that either are developing or have already developed. So that's why you see a diabetic, and they don't just have blood sugar issues, they have cholesterol issues, they have blood pressure issues, they have all these issues, right? So once you knock that one domino down, it's all bets are off for what else can happen.
But that's not how people look at it, right? I get people always coming and telling me, you know, I don't have any medical problems. I just had one stent put in and I'm on a medicine for heart disease. Otherwise, I'm healthy. And yes, I know it's almost like, so why did you have that one stent? They don't know. My cholesterol was not too bad, but I just have that one stent. I think it's family history. My grandfather had it, my cousin had it, and it goes. It's like we've changed our thinking to accept what a dysfunction or disease is actually normal. So they come to you, and if they're not tuned to what functional medicine is, it's almost they feel like you're trying to tell them, no, there's something more that you're missing. And it's like, no, if my doctor has checked me out, I have no other problems. I just have this one issue. So insulin resistance actually for me is when you really look at the history or the physiology behind insulin resistance, your body is protecting you from something. And when you look at the history of polycystic ovarian syndrome, and it was really described even by Hippocrates, according to all of the history, where they have this masculine looking women who never bear children. But when they're, and you know, we're trying to piece together, why does PCOS even exist over the, you know, why was it there in the ancient years? Because they didn't have processed foods, because we're talking about insulin resistance. And it was thought to be where when there's scarcity, somehow the body develops this ability to kind of store fat, and fat increases your insulin resistance. And that's why just weight loss will reduce your insulin resistance. Did you get something from Disney?
No, it's just a tickle. If I talk too much, I start to get dry.
Well, you should start talking more, John.
Yeah.
So anyway, so I was just saying, you know, insulin resistance in those days was something as a protective mechanism. Even today is a somewhat a protective mechanism, but we're under a different kind of stress.
Yeah. Well, I think what the take home is what you're saying is, you know, medicine is just going to say, hey, you're broken. We can fix it, or hey, you're broken, but it's normal to us. What you and I are saying is the body's, and this is a tenet of chiropractic philosophy, the body is always intelligent. So, you know, a cancer cell is the body made an intelligent choice between I'm going to die slowly instead of acutely, right? So if you have insulin resistance, the body is making a choice. It's adaptive physiology to protect you from something more acute. So in other words, you're basically going to, it's going to let you die slowly instead of acutely.
Right.
Well, conventional medicine lives in acute. If you don't have a tumor, a fracture, or a hemorrhage right now, you're normal until you do. This is what I tell patients. So that's why when they're like, well, I feel so bad, but they always tell me I'm normal. Well, because in their world, they're all about, are you going to die today? If you're not, you're normal. So that's why they're terrible with chronic stuff. Well, functional medicine excels with chronic stuff because we can take the time and do this detective work. But if you break your arm or have a tumor or you're hemorrhaging, don't come to me. That's not my wheelhouse. That's them. So what we need to understand is who should we see for a given situation. And that's where conventional medicine markets like they're the only answer for everything, but they're really the only answer for tumor, fracture, hemorrhage, right? Acute, life-threatening things.
And heart attacks and strokes. I would say anything acute, right?
Yeah. Which I would lump under hemorrhage. But you know what I say to patients: if I get hit by a bus, don't take me to me, right? Take me to the hospital, save my life. But then when it's time to get healthy, I need to see me. Okay.
Right.
So.
So to just summarize, now, where somebody who's you know, struggling with infertility, has done everything but does not have the money for IVF, what should they be doing? I know you mentioned gut in part of the hormonal abnormality. And a lot of times, I think if we can get that fixed, because that's your connection to the outside world, really what you're putting into your body comes through that, whether it be medicine, supplements, or food. And of course, the skin and the air is what you put on your skin and inhale, but mostly the gut, the biggest load. And that's very true because your biggest, strongest detox organ is the liver. It's supposed to really be able to differentiate between what is a toxin and what is actually healthy for you.
Right.
So when you really look in the broad spectrum, can we put it as, hey, you have an immune issue, you have an inflammation, which will be lumped under infection and underlying infection, and probably a genetic predisposition if your environment is not correct, and of course, exposure to toxins, which comes back to your ability of your body, the immune system, to identify the toxin, and then your detoxification system to actually get rid of it. I think that also needs to be, would that cover, are those the hidden things that probably the conventional system will not look for? Did I cover pretty much what?
Yeah. I would just, the last thing I would put in there is your kidney function, because that's the third of the big three in terms of detoxifying. I mean.
So why would the kidney function be affected in a young woman? Or I'm assuming young, I would say right now would be anywhere from 25 to 45.
Yeah, I mean, if they have pelvic inflammatory disease, if they have a history of, you know, chronic UTIs or interstitial cystitis, or, you know, if they have renal artery stenosis or, all kinds of different things. So just understanding as the clinician, hey, these are the three main organs of detoxification. So let's just make sure I'm looking through the history. Anything that flags me, hey, maybe kidney. On the labs, anything that flags me, hey, maybe kidney. Maybe it's not, but we just want to make sure we're at least considering that.
Okay. So really, when you get a person who comes to you because of infertility, when you start working with them, obviously, first one is the detective work. How much do you see a lot of food sensitivities in patients with infertility at all?
That's not, I have to say personally, that's not a huge priority for me, because if there's immune imbalance, then we have to take care of that. And most food sensitivities are going to be because of immune imbalance. So if we clean that up, so for me, food testing is way down the road if things don't improve like we would expect them to. I never lead with the food stuff, because if I lead with the food stuff before knowing the status of your immune system, we could get false positives or false negatives and be chasing our tails.
I always tell people it's a gut issue. You got to look at your gut, because you shouldn't be sensitive to what you.
But to your point, though, I mean, if their infertility is driven by an autoimmune process, then foods matter, because many foods are cross-reactive with soft tissue. So then, consuming certain foods may flare or worsen the infertility. Yeah.
Right. So they come to you, and then you do the deep dive into their investigation, for listening to their history. How do you approach them? Do you start with, let's do nutrition, or do supplements? Do you do detox, or you do everything together? What would be your approach?
I approach, sorry for the ambiguity, but because I build it to the person, but whatever the findings are, whatever the findings are on the testing, I'm going to then prioritize based on that person. And so, you can't do everything at once. So we can't dump, immune and detox and this all at one time. So I have to say, okay, in Nisha's an onion. We have to put the layers of the onion back together. So the highest priority layer we're going to do first, and then we're going to put the next layer and the next layer and the next layer. And at certain periods along that time, we're going to retest to say, are we objectively achieving what we've set out to achieve, plus subjectively, how are symptoms improving and that sort of thing. So it's nuanced to the person.
And I think that's very important for people to understand, is because we're, once again, trained to go to a doctor and get a solution, a quick fix, right? Yeah. I have a problem with infertility. Give me something to make me have a baby right now. Whereas when you go to a functional medical doctor, you're looking at it in a stepwise fashion, because infertility is not something you're born with. It's something that you develop. Well,
and I think our society is, the brainwashing is look for the magic bullet, right?
Right.
And that's what the whole drug paradigm is built on. We found the magic bullet. And then a year later, after 50,000 people have died, they pulled off the market.
Right.
So what I tell patients is the only magic bullet is consistency. And that's what teaches us what they should be expecting. The only way you're going to undo whatever you're dealing with is consistently making the right choices and providing the right nutrients and removing the right toxins over time. There's no magic supplement, just like there's no magic drug, or there's not even a magic diet. It's what's the right thing for the person in front of me, and can you do that consistently over time? I'm not doing it to you. My heavy lifting is figuring out, then you have to go do. If I figure it out and you don't go do, we're still in the same place we were when we met.
Right. I know this is probably the most important thing, is consistency. When people eat healthy for about 2 weeks and they don't see a difference, they are completely like, hey, we're not on the right track here. Right.
But you are. The problem is, are you doing it as strictly as the doctor recommended, or have you had just a taste here or there, right?
Oh, yeah.
So you may not be doing it as strictly as possible, or you may be so inflamed and you may be 40 years old and you've never eaten healthy, and it's going to take 8 weeks to reduce the inflammation and get energy back and that sort of thing. So, Rome wasn't built in a day, right?
Yeah.
And if they give you a drug, they don't say take it, unless it's antibiotics, they don't say take it for 2 weeks and then stop. They say, here, take this the rest of your life, right? So, You need to give yourself time and realize that there's no magic bullet. You have to do it consistently.
Right. Right. And I think it's very important for people who struggle with infertility also to remember a few things. When they do the studies on infertility, or they've gone back and seen, people who complain, and I think the study was done mostly in women. And the reason women are blamed for infertility in many cultures across the world, may not be in the United States, but in a lot of cultures across the world, the men do not get tested. So when you have the statistics, it's mostly female infertility. It looks like it's 30% higher than male infertility. But in general, when you are infertile in your 20s and 30s, one of two things would have happened. You would have gotten the IVF and had a baby with some kind of assistance. And then later on, you'll end up having medical problems, chronic medical problems, which you don't connect to your infertility. And I think that's very important to understand. Infertility is not just about not having a baby. There's something wrong. And I've heard you use this word before. I don't know under what topic, something is wrong with the terrain. And if something is wrong with the terrain now, not to have a baby, and you forced your body to have the baby, later on, when you have the diabetes, when you have the thyroid, when you have the arthritis, and eventually have dementia, they all began with when we failed to find the cause of the infertility 40 years ago.
Yeah.
And a lot of times people don't realize that. That's why infertility is just a symptom of an underlying problem. It's not a condition, right?
Yeah.
Okay.
Yeah. And one other thing, and I need to read further on this, so don't ask me too many in-depth questions, but I've seen some articles lately saying that when they study babies of IVF babies, like a couple generations out, they're infertile, the IVF.
Really?
The offspring of IVF born babies.
Maybe they just got all those antibodies transferred.
Yeah. So I need to follow up on that further, but that was interesting because again, you may accomplish your goal of having the baby today, which is awesome. We can never take away from you, but then from an evolutionary perspective, it's like, well, at some point we're creating a family line that's going to end because of the choices we're making today. So, maybe save IVF as the last ditch thing.
Yeah.
Go see the doctors, a functional medicine provider that can do this detective work and find out whether or not you truly don't have a choice other than IVF and go from there.
And that's exactly what I tell patients. It's like, I think health should be looked upon just like wealth. Somebody who gets wealthy does not do his taxes or her taxes on their own. They actually have an accountant. They have a financial advisor. They might have somebody else who actually looks at there are different types of financial advisors too. And you're looking at both income and outflow, and you're constantly monitoring it if you're really trying to build wealth. Same thing with health is you need to have a team of people. Everybody has, whether it be a chiropractor, naturopath, MD, or a functional medical doctor who can come from any different backgrounds. A team actually will help you get back health. And somewhere we have to create that atmosphere where we're going to be able to talk to each other and help the patient. That is true patient-centered medical care.
Right.
And I think hopefully someday we'll get to that point. So in terms of health, what do you do, John, for your health? What is this thing that you do consistently that keeps you healthy?
I practice what I preach, which includes
means what? Yeah.
Which includes the proper nutrition, the proper physical activity, the proper sleep hygiene, the proper toxin avoidance, the optimization of stress levels. So if you want to dig in deeper,
what's your routine? That's what I want to know.
I wake up at 4:45 every day. I work out. I have mindfulness practice, and then I have a study period, and then my family wakes up. I have 4 kids and 1 in the oven, so I wake up and get them going, and then I get off to work. And then nutritionally, I'm completely gluten-free, dairy-free. I'm gluten sensitive, so if I eat it, it affects me neurologically. Dairy affects my gut, so I avoid all that. You know, and then, you know, optimizing stress and optimizing sleep and avoiding toxins, like those are kind of the 5
So how do
pillars
you
that,
optimize stress? I think that's a big challenge, right?
yeah. And so for me, optimal sleep is huge in optimizing stress, because if your sleep is off, that's the fastest way to jack up your HPA axis and cortisol levels.
Right.
But then also starting my day with that victory hour, as I call it, the exercise, the reflection, the learning, allows me to dictate to the day how my day is going to be, instead of like waking up, hitting snooze, and then running from there, you know? So if you just build margin into your schedule, you'll realize you're a lot less stressed, because you gave yourself time to do what you want to do most that day first, right? And then go do the rest.
Right, right. So do you ever fall off track?
Sure.
And how often would you say?
Well, I never miss a workout. I don't eat gluten. I'll have cheese on a burger sometimes. Sleep is probably the easiest thing to fall off, because of family and staying at the office late and things of that nature. So, you know, for me personally, sleep is probably the hardest one to do the best at.
But that's true. That's true for everybody in our profession. And in many ways, I think we've trained ourselves to have less hours of it. I just don't know what I will do if there was a time that I didn't have to work, if I would actually sleep. And I don't think it'll happen, because I just want, you know, I don't need to look at my clock. I just know what time it is.
It's time.
Yeah, I know. And then when I look at the clock, it just corroborates with what I'm thinking in my head. Yeah. So
why am I always right?
I know. So for people, is there any other question that I haven't asked? And I know there are some people watching, but no one will ask questions. That's how we have it, unless I'm talking about ketogenic diet, then everybody asks questions. So, anything that's a fad. So infertility was not a fad, but it was very important, because I realized that a lot of chronic issues that I see in the 50s, many of these women have struggled with infertility much younger. Is there some question I did not ask that you wish I asked you?
Well, I think just to the point you just made, if we go back to the premature ovarian failure woman that has ovarian antibodies.
Right.
Because the conventional medical and most functional medical doctors don't even know that exists and don't check for it, you may have gone through, you know, your fertile years and never had that found, and now you're in your 50s or so and you're still having issues, because the damage to the ovaries and maybe drove you to early menopause, and so now the hormone shifts happened earlier in life, and so you're skewed that way. But B, if you have an autoimmune process, oftentimes, if it's not being dealt with, you start to collect them over time. So maybe you started with ovarian antibodies, and then, now I have Hashimoto's, and now I have psoriasis or something. So this is the part where Dr. Nisha was saying problems you have down the road stem from that. Well, that's one theoretical mechanism that may have resulted in it for you.
Got it.
So,
No. Well, anyway, I think we have given them enough information to think about and reach out. And if people want to get hooked onto your videos like everybody else does, where do they go?
The most direct way to go would be youtube.com/C/Dr. John Bartemus.
Okay.
Or if you just go to YouTube and you type in the search bar Bartemus, my last name, Bartemus, my channel will be one of the first things that pops up, and you can just go subscribe from there. And I'm currently at almost 700 videos. So once you get to my channel, you can search on my channel for food sensitivity or hormones or whatever you're looking for, and probably have videos pop up for you.
Very nice. Well, thank you so much for your valuable time and all of the information. And it'll be on our website. I didn't know how to share it to your little group. So if you want to just get on it, and not our website, our Facebook page.
I'll
I'll send you a link too.
All right, I appreciate
right.
it. Thank you, everybody. And lastly, just my website is www.functionalmedicinecharlotte.com. And thank you for all you're doing, Dr. Nisha, to educate and empower your followers.
Thank you, and thank you for being a part of it.
You're welcome.
Bye-bye.